Hello, this is Konstantinos Papadopoulos from Greece, and in this tutorial we are going to talk about how to evaluate atrial septal defects and how to guide the interventionist for transcatheter closure. These are my disclosures. So, atrial septal defects, it is a defect at the atrial septum allowing pulmonary venous return directly to the right atrium. They account for approximately 6 to 10% of congenital heart defects, and it is the most common cyanotic congenital lesion. The most common symptoms in patients with ASDs are exercise intolerance, shortness of breath, arrhythmias, and right-sided heart failure. And depending on the size and the shunt, it may cause right-sided volume overload, pulmonary arterial hypertension, and arrhythmias. Most of the ASDs are diagnosed until the fifth decade of our lives. These are all the types of atrial septal defects, and the most common one is ostium secundum. We also have ostium primum or AV canal. We have sinus venosus and the coronary sinus. From guidelines, we know that echocardiography is the method of choice for diagnosing ASDs and quantification, of course, of RV volume overload, for example. And if echocardiography if the images are not optimal, then we can use other modalities like CMR or CT. And of course, when we are not sure about the pulmonary vascular resistance, we can do a cardiac right heart catheterization in order to estimate the PVR and, of course, the systemic pressure. One thing that we should know from the guidelines is that when we have Eisenmenger physiology, it's a contraindication to do an ASD closure. And of course, we have to know that if we have a patient with PVR below 5 Wood units, then we can do an ASD closure, and almost always with a transcatheter device, except for the patients that are not suitable for an ambulatory occluder. Sometimes we can go further, more than 5 Wood units. We can go up to 7 or more, but then we have to be careful. We have to give oxygen to the patient, and we have to know that after the occlusion, he won't have any compromise of the right ventricle. The role of echo, first of all, is to identify that the septal defect is present. Then to recognize the type, we have to measure all the rims and the size of the defect, and we have to assess the hemodynamic effect of this shunt, the right atrium and right ventricle dilatation. We have to check for septal flattening, the elevated systolic pulmonary pressure. We have to see about coexisting cardiac abnormalities like anomalous pulmonary venous return. Echocardiography is indispensable for transcatheter intervention, of course. And after the implantation of the device, we have to check about embolization of the device, the residual shunt, the position of the occluder to other structures, the pulmonary pressure, and of course, the functioning of the atrioventricular valves. From all these types of ASDs, in this tutorial, we're going to talk about the secundum, because it is the only ASD that can be managed with transcatheter occluders and not surgically. In this slide, we can see a step-by-step approach for TOE diagnosis of these ASDs, and then preparing the patient for transcatheter guidance. First of all, we have to acquire images of the septum at 0 degrees, 45 degrees, 90 degrees. And if we are not satisfied with the images, then we can take additional views every 30 degrees of the septum. We have to measure all the rims and the defect size for possible transcatheter intervention. The rims have to be more than 5 millimeters and ideally more than 7 millimeters, except for the aortic. And the size should be ideally below 38 millimeters in order to find an occluder that will be enough to close the defect and not be embolized. We have to measure the defect size simultaneously with 2D imaging and color Doppler. We need to reduce the color scale in order to acquire low velocities, and we also have to use the pulse wave Doppler in order to assess the direction of the sound if it goes from the left to the right atrium, or vice versa. Always we need to check the total length of the septum, because if the occluder disc is more than 90% of the septal length, then it may cause an erosion, and we don't want that, of course. From all the rims, we can say that we don't care if we don't have the aortic rim, but the IVC rim, the inferior vena cava rim, is the most important, because if it is absent, this is an absolute contraindication for a transcatheter occlusion. And of course, before we finish our case, we have to visualize all pulmonary veins, the left and the right, and we have to check that they all go directly into the left atrium. This is the protocol that we use in transesophageal echo, and as you can see, from 0 degrees to 90 degrees, we demonstrate, we visualize the septum from all these angles, and then we go step by step from 0 degrees in a modified four-chamber view tilted to the right, where you can see here the septum. And in this view, in 0 degrees, we can check the atrioventricular rim, which is near the atrioventricular valves. We can check also the pulmonary venous rim, which is near the right pulmonary veins. And we have to measure the length of the rims, the total length of the septum, and of course, the size of the defect. We can use the color Doppler in order to see the direction of the sound. Then we go to 45 degrees at short axis view, where we can evaluate the aortic rim, which is near the aorta, and the posterior rim, which is at the opposite side. Of course, we measure the rims and the total length of the septum. Then we go to bicaval view at approximately 90 degrees, and we measure the superior vena cava rim, which is near the superior vena cava, and the inferior vena cava rim, which is near the inferior vena cava, and of course the total length of the septum. We have to say that depending on the anatomy of every patient, perhaps we have to change the degrees of our angulation and not be so strict to go to 0, 45, and 90. We can change it depending on the patient. We can take triplane views of the septum. In this case, you can see that we have a defect, and at the same time, we can visualize from a different angle. For example, in this case, this view is a bicaval view. This is a modified four-chamber view, where this is the atrioventricular rim, this is the pulmonary venous rim, and this is a left inverted short axis view. You see the aorta here, so there should be the aortic rim. There is no aortic rim in this case. And this is the posterior rim. But with triplane views, we can check at the same time all the rims of our defects. We can use 3D echocardiography in order to have an unfast view directly of the defect. And here you can see a not very circular defect at the fossa offalis. And we can, of course, measure the minimum and the maximum diameter of the defect, which would be very important for the device that we are going to implant. 3D echocardiography plays a very important role in order to evaluate different sizes and different shapes of the defects. Here you can see a very, very small defect, and here you can see a defect with aneurysmal septum. Two rims were not present, so this case would go surgically. This case with a very small defect, we didn't do anything. This is an oval-shaped defect, and here you can see another defect with different shapes. So 3D echocardiography can help us understand what kind of a defect we have. And of course, sometimes we can see a septum with multiple fenestrations. And this is very important also. For occluder devices, there are many companies that have ambulager occluders. The most commonly used is this 2 discs occluder which consists of a larger left atrial disc, a smaller right atrial disc, and a waist in between. And as I said before, the ideal length of the rims should be 7 millimeters because the length from the waist to the edge of the left atrial disc is 7 millimeters. So if we want all the rims to go all the way into the waist, then we should have 7 millimeters of rims. But if we have 5 millimeters, then it's okay to put an occluder safely. So let's see some cases, if they are suitable for ASD closure or not. And then we will go through 2 cases that performed a transcatheter occlusion. In this case, from transthoracic echo, you can see directly from the 4-chamber view that we have very dilated right cavities, a septum that is going towards the left atrium, and a bidirectional shunt from left to right and right to left, and of course absence of a big part of the atrial septum. QPTQS was measured at 3.8. You can see the flattening of the septum and dilatation of the right ventricle. The flattening is diastolic and systolic, which means volume and pressure overload. And then from TOE evaluation, this was the bicaval view where we can see that we have a superior and inferior vena caval rim. We didn't have the aortic rim, but as we said before, it doesn't mind. We had a very nice posterior rim. But at 4-chamber view, we saw that we also didn't have a atrioventricular rim. And of course, we measured the length, the diameters of this defect, and we saw that it was 4.4 centimeters to 4.1 centimeters. So this is a triplane view of this defect. As I told you before, we don't have aortic rim, we don't have atrioventricular rim, and all other rims are present. So what do we know about this case? There is absence of 2 rims, one aortic, one atrioventricular. We have a size 41 to 44 millimeters, which is more than 40. We don't have an occluder of this size. And we have severe pulmonary hypertension, QPTQS 3.8, and we have a bidirectional shunt, which means that the patient is going towards an ischemic physiology. So for all these reasons, this patient was this patient was not suitable for ASD transcatheter closure device, and we were not sure if he had to go surgically to close this ASD or not. So let's go to an ASD closure case. An 18-year-old female patient which was complaining about palpitations. She had a known ASD from her childhood. The transthoracic cardiac echo showed the dilated right ventricle, ejection fraction of 60%. QPTQS was 2, and moderately elevated pulmonary pressures. We performed the transesophageal echo in order to check the atrial septal defect, and we saw that in 0 degrees, in 4-chamber views, we had a very nice atrioventricular rim here, a very nice pulmonary venous rim, we had aortic rim, we had posterior rim, and of course we had a superior and inferior vena caval rim. All rims were very were nicely visualized. We measured the defect. You can see from 3D echocardiography that this was an oval-shaped atrial septal defect, and we measured it at 28 the maximum diameter, tuned to 20 millimeters. So we considered this case to be suitable for transcatheter closure, and we proceeded to the implantation of an ambulatory occluder device. The first step was to go from the right atrium to the left atrium with an extra stiff wire through the defect, and then we advance over the wire a balloon in order to do a balloon sizing, so as to check which is the diameter in which there will be no flow from the left atrium to the right atrium. So the interventionist inflates the balloon, and then we have to check if we have flow or not. Then we measure the balloon and we decide about the device that we are going to include. Usually we put a bit bigger device than the one that we measured. So in this case, we put a 30 millimeters Ablager Septal occluder device. The next step is to follow the opening of the discs. We have to check the left atrial disc, which comes towards the septum, and then we have to check the opening of the right atrial disc. And it is important to see the left atrial disc hugging the aorta, as you see here, in order to avoid possible damage and erosion of the aortic wall. So the next step is to visualize all the rims in between the two discs, and if we think that the device is very nice situated, then the interventionist pulls back the right atrial disc in order to check the stability. We put a color Doppler in order to check for residual sand. You can see through the device there is a bit of flow, but we don't care about this flow because after 3 or 6 months there will be endothelialization and this flow will go away. We don't want to have flow from both sides at the edge of the device. So we do our final assessment. We check the device at all views: 4-chamber view, short axis view. We see we have the rims, and then we can have a very nice 3D imaging of our device. And of course, we have to follow up these cases. We can have a transthoracic echo 1 week later, 1 month later, to check if we have residual sand and if the device is stable in its position and it hasn't embolized to a cardiac cavity. Another case that was very challenging, and it was not so easy that the previous one, was 1 month ago. A 54-year-old female patient with shortness of breath, palpitations, and pedal edema. From transthoracic echo, she had dilated right cavities, an atrial septal defect that was confirmed with transesophageal echo. We measured a QP-TQS at 2.1. We saw that we had a left to right shunt. The dimensions of the ASD were 26 to 15 millimeters. There was no aortic rim, but all other rims were present. And we saw that we had a thin and mobile IVC rim. So this case was considered operable and suitable for transcatheter closure device. And let's see some images of this case. In this triplane view, you can see modified views of bicaval view with inferior and superior vena caval rim. This is a modified 4-chamber view. This is the tricuspid valve, so this is the atrioventricular rim. This is the posterior rim. This is the aorta, so this would be the aortic rim. We don't have aortic rim, but we have a nice thin but nice posterior rim. This is 3D advanced views of the septum, and if we increase, this is with low frame rate, where we increase the spatial resolution to see better the anatomy, and if we increase the frame rate, We increase the temporal resolution and we decrease the spatial resolution, but we can appreciate that in this part of the fossa vallis, we have a kind of aneurysmatic and thin mobile septum. And we thought that this would be a small problem for the stabilization of our device. However, we proceeded to this operation. The first step, of course, is to go with an extra stiff wire towards the left atrium, as you can see here. We advance the balloon again. We do the balloon sizing. This was a balloon that was measured at the maximum diameter at 26 millimeters. And we had a very small flow here. So we decided to implant an ambulatory occluder of 28 millimeters. Then we follow again the opening of the left atrial disc, which goes towards the septum. We always use a short axis view in order to see the aorta. We have, I will say again that the left atrial disc has to hug the aorta and not to cause any erosion of the wall. And then we follow the opening of the right atrial disc, as you can see in this view. However, the interventionist said that we were done and the fluoroscopic view was very nice, but from transesophageal echo, from 2D images, I saw that both discs at the posterior rim were not in an ideal position. And I confirmed that with the 3D imaging, where we can see in this view that from one side of the septum, both discs, the left and the right atrial disc, seem to be above the septum and both into the left atrium. So we discussed it with the interventionist. From the imaging side of view, we said that we don't feel safe to release this device because it might be embolized into the left atrium. So we advised the interventionist to reposition the device. And as he did, you can see this view with the repositioning of the device. The right atrial disc goes below the posterior rim. And this was the final position where we see that we have a very nice result with all rims in between the two discs. And we were satisfied from the echocardiographic view. And this is a comparison of the two views, the first before the repositioning, and the right one is the final position of this occluder, where you can see that the rims are between the two discs. And this was the final 3D imaging of our device. The patient at follow-up had a very stable device at the septum without any residual shunt. And of course, clinical symptoms were better than before. So we were very happy about this collaboration with the interventionist. So in concluding, you can see that atrial septal defect needs a very nice collaboration between interventionists and echocardiographers. A strong heart team is needed for successful transcatheter interventions. 3D echocardiography may facilitate the guidance of the procedure. Interventionists should follow the steps of the imaging specialists. And of course, the final call for releasing the device and finalizing the operation is on the echocardiographer that should check all the rims, should check the stabilization of the device and say that we have a good result and we can release the device. So thank you all for attending this tutorial. I hope that with this 20 minutes video, all questions you had about ASD defects, diagnosing and guidance for transcatheter closure were answered, and I hope to see you soon. Thank you very much.